Hello, I'm Dr. Rafael Escamilla, professor in the Doctor of Physical Therapy program and director of the Biomechanics Laboratory here at California State University, Sacramento. In this segment, we're going to be talking about the structure, function, and pathology of the ulnar nerve. The ulnar nerve originates from the brachial plexus. Specifically, it's a terminal branch and direct continuation of the medial cord, receiving C8 and T1 nerve fibers and often C7 nerve fibers as well. So it's a C7 to T1 mixed peripheral nerve. Mixed meaning it contains both motor and sensory nerve fibers. So I want to first give an overview of the motor function of the ulnar nerve. So when you think of the ulnar nerve, it receives motor fibers that are going to innervate the 1.5 muscles in the anterior compartment of the forearm. The other 6.5 are median nerve. So the 1.5 muscles are the flexor carpi ulnaris, which is going to originate on the medial epicondyle for one head and the olecranon down here for the other head. And then it's going to come and insert on the pisiform in the base of the 5th metacarpal. So it crosses the wrist anteriorly and medially. So it flexes and ulnarly deviates the wrist. So that's one of the 4 superficial muscles in the anterior compartment. So with an injury, that could be some weakness in flexion and ulnar deviation. Then it innervates 1/2 muscle, and it is going to be the flexor digitorum profundus, the medial half. The lateral half is innervated by the median nerve. So what does it do? Well, first of all, it originates on the proximal ulna and the interosseous membrane. It's going to come down the forearm, under the transverse carpal ligament, through the carpal tunnel to the lesser 4 fingers. It's going to go deep to the superficialis tendons until it goes into the fingers, and it's going to go up through a slit and insert into the base of the distal phalanx. So one of the ways you can test for its integrity is stabilize the middle phalanx like this and flex the distal phalanx. So you're flexing dip, or the distal interphalangeal joint, like I'm showing right here. Okay, so that's it for the muscles in the anterior compartment. Just 1.5 muscles. The remaining 6.5 of the 8 muscles, known as the flexor pronator mass, because that's what they do functionally. They flex the wrist, fingers, and thumb and pronate. It only is going to innervate the medial 1.5. Most of the muscles that it innervates are in the hand. It innervates all the intrinsic muscles in the hand except for 2.5 muscles in the thenar region that control the thumb and the lateral 2 lumbricals. Those are median nerve. Everything else is innervated by the ulnar nerve. So let's go through those. First, there's 3 muscles in the hyperthenar region right here. They all originate on the medial flexor retinaculum and the medial carpus, your pisiform and your hamate. And the most ulnar one is going to be the abductor digiti minimi, inserts into the base of the proximal phalanx, and it's going to abduct the little finger like this. And then the next one is going to be the flexor digiti minimi. It's going to insert into the base of the proximal phalanx and flex the little finger at the metacarpal phalangeal joint. And then the last one is the opponens digiti minimi. It's going to insert over here on the 5th metacarpal and help with opposition of bringing the little finger over to the thumb. So those are the 3 muscles in the hyperthenar region, and if you have an injury to the nerve, those particular functions we just went over could be affected. Also, you have the medial 2 lumbricals. So the lateral 2 lumbricals are going to be innervated by the median nerve. So these are bipinnate muscles that originate on the tendons of the flexor digitorum profundus. They're worm-like muscles. They work their way up, and they're going to insert into the oblique fibers of the dorsal hood. So notice that when they come in, they're going to come on the palmar surface more. So they produce a torque that's going to flex the metacarpal phalangeal joint because they're below, as you can see here, when they're coming into the oblique fibers. And then they're coming into the extensor mechanism. So tension from the oblique fibers is transferred to the central band, which runs along the dorsum of the proximal phalanx, inserts into the base of the middle phalanx. Lateral bands come off of it down here, and it's going to form a terminal tendon that's going to insert into the base of the distal phalanx. And through this extensor mechanism, the tension that starts with the oblique fibers is going to help produce a torque that's going to extend the pip and dip, the proximal and the distal interphalangeal joints. So when you think of the lumbricals, think of the lumbrical grip. It's a common grip used in manual therapy, such as proprioceptive neuromuscular facilitation, where you flex the metacarpal phalangeal joint and you extend the pip and dip. But it's only going to do it for these medial two fingers for the ulnar nerve, the little finger and the ring finger. So if you have a problem with the ulnar nerve that affects the lumbricals, you have to make the lumbrical grip, then these two fingers do not want to work very well on the medial side. The lumbrical grip on the lateral side is functional from the median nerve. So those are the medial two lumbricals. Then the next are the interossei. You have 3 palmar interossei and 4 dorsal. Let's start with the palmar. The palmar interossei, the way you remember what they do is pad. P for the palmar interossei and AD to tell you they adduct the fingers. So when the fingers are abducted like this, they bring the fingers into adduction, adduction. There's 3 of them, so they're going to be unipinnate muscles where they originate on the same side that they insert, either radial or ulnar. So let's look at that. They're going to go, like the name says, interossei, they go between the metacarpals. So in this case, they're going to go, the first palmar interossei is this muscle right here as far as its origin. So it's going to originate on the ulnar side of the second metacarpal, and it's going to come up and insert into the base on the ulnar side of the proximal phalanx. So it's in position to bring the index finger in toward the middle finger. So again, its origins here on the ulnar side of the second metacarpal, and its insertion is over here. Then the next one is going to be the second one, palmar interossei, is going to originate on the radial side of the fourth metacarpal, so in here, and insert on the radial side of the base of the proximal phalanx. So since it's coming over this way, it can pull the ring finger in toward the middle finger. And the last one, palmar interossei 3, is going to be over here on the radial side of the fifth metacarpal and insert into the radial side of the base of the proximal phalanx, so it can bring the little finger in. So in that way, the palmar interossei, they adduct and they also help the lumbricals produce the lumbrical grip through the extensor mechanism to flex the metacarpal phalangeal and extend pip and dip. If we turn our hand over like this now we have the 4 dorsal interossei. So the first one, these are bipinnate muscles, so which means they're going to originate on adjacent metacarpals. So dorsal interossei 1 is going to originate between the first and the second metacarpal bones, and it's going to come over and insert on the radial side of the base of the proximal phalanx. So DAB is how you remember the dorsal interossei. D for dorsal interossei, and DAB, AB, for abduct. So they abduct the fingers, they bring it out. So it has to be over here on the radial side in order to pull the finger out. Now this is an interesting one, the dorsal interossei, because it attaches to the first metacarpal, it can also move the thumb. When the thumb's down here in abduction, it can move it up in adduction, ADD. So abduction, adduction, and it can also flex it over. So for example, using a key to get in a house, putting pressure of the thumb against the index finger, you can feel very prominently the first dorsal interossei. And with an injury, this muscle could weaken and it could also atrophy and produce a concavity that's very apparent with ulnar nerve pathology. The second dorsal interossei is going to originate between the second and third metacarpals, and it's going to come up and insert on the radial side over here of the base of the proximal phalanx of the middle finger, so to bring the middle finger over toward the radial side. And then the third dorsal interossei originates between the third and the fourth metacarpals in here, and it's going to come over and insert into the ulnar side of the base of the proximal phalanx, so to bring the middle finger over to the ulnar side like this. And the last one is going to be over here between, the origin is between the 4th and the 5th metacarpal, and it's going to come and insert onto the ulnar side of the base of the proximal phalanx, so it can bring the ring finger into abduction. And the dorsal interossei also help the lumbricals produce the lumbrical grip, where they flex the metacarpal phalangeal joints and they extend pip and dip. So those are the function of the lumbricals and the interossei. Hyperthenar muscles, the only muscle left for the ulnar nerve is the adductor pollicis. So that's a muscle that originates as two heads, one along the 3rd metacarpal, the other one on the capitate and the base of the 2nd and 3rd metacarpal. It's going to come over and insert into the base of the proximal phalanx. So it can be stretched when you abduct like this, so its function is to adduct, to bring the thumb down. So this is abduction, adduction is bringing it down. You can test it better like this, holding your hand in this position, and then you have the patient bring their thumb up in this manner, and then you hold it there and you try to push it back down, like in this direction here. And that's also assessing the integrity of the first dorsal interossei as well. So those are going to be the functions of all the intrinsics of the hand that the ulnar nerve innervates, with one exception. It innervates half of the flexor pollicis brevis muscle, the deep half. The superficial half is, superficial head is from the median nerve. So the deep head, the flexor pollicis brevis, this muscle right here that flexes at the metacarpal phalangeal joint, is also innervated by the ulnar nerve. So all these muscles in the ulnar nerve are C8, T1. Most of them are primarily T1, except for the muscles that control thumb motion. They're more C8. So that's a good summary, I believe, of the motor function of the ulnar nerve. Now, sensory is very simple. When you're thinking of sensory, you're simply thinking of the medial 1.5 fingers in hand, both on the palmar surface here and on the dorsal surface. So the little finger and half of the ring finger is sensory, and the medial hand over the hyperthenar region, and then on the other side, same story. The 1.5 fingers and the medial hand in here. So that's your sensation. If you have an injury to the ulnar nerve, you could have abnormal sensation. You have a higher density of sensory receptors in the pads. So these two medial fingers are more likely to experience pins and needles, numbness, tingling type sensations with an ulnar nerve lesion. So that is a summary of the motor and sensory function of the ulnar nerve. In this next segment, we're now going to trace the ulnar nerve as it runs down through the entire upper extremity and see where the motor and sensory branches come off, the muscles they supply, the skin they supply, potential impingement sites that the nerve can be impinged, compressed, or stretched along the way, and subsequent sensory and motor deficits and signs and symptoms that go along with an ulnar nerve injury. So, first thing to realize is the ulnar nerve is going to run down the medial arm, posterior medial, to the axillary artery. When it gets about halfway down, it's going to go through the medial intermuscular septum, which divides the anterior and posterior compartments of the arm. So it's going to go posterior. So it's going to run posterior through the septum, and then it's going to go under the arcade of Struthers, which is a fibrous arch that goes from the septum to the medial triceps. And this is the first potential place of impingement, is in this arcade of Struthers. Now, if it's injured in the arm, everything distal to it is going to be affected. Everything proximal, motor and sensory, is going to be intact. But there is nothing proximal, motor and sensory, to the arm. Everything motor and sensory is in the forearm and in the hand. So potentially, all the muscles that I went over in the sensory earlier could be affected with an injury to the ulnar nerve in the arm. This is referred to as a high injury, high ulnar nerve injury when it's in the arm. So you could have weakness in wrist flexion and ulnar deviation from the flexor carpi ulnaris, weakness in being able to flex the medial two fingers from the medial half of the flexor digitorum profundus. So there's your 1.5 muscles here. You could have, in the hand, you could have weakness flexing, abducting, and opposing the little finger from the flexor digiti minimi, the abductor digiti minimi, and the opponent's digiti minimi. And then from the dorsal interossei, dab, you could have problems abducting the fingers. The palmar interossei, pad, difficulty adducting the fingers in this manner. The medial two lumbricals, so difficulty maintaining the lumbrical grip for these medial two fingers, which is flexing the metacarpophalangeal joint and extending the pip and dip joints here. And finally, difficulty adducting the thumb up like this. All those can potentially occur with a high ulnar nerve lesion where all the motor and sensory is affected. That's motor-wise. What about the sensory? Again, is going to be the medial 1.5 fingers and hand, both on the palmar side and the dorsal side, with a higher density of receptors in the pad, so more tingling, pins and needles are going to be more experienced in that area, numbness, than other parts of the hand potentially. But with a bad enough lesion, you can feel it everywhere along the medial hand and medial 1.5 fingers. So that's a high ulnar nerve lesion. Then the ulnar nerve is going to continue down the posterior medial arm, and then it's going to go posterior to the medial epicondyle, which is over in this area here. And that's another potential site of injury with medial epicondyle fractures. And then it's going to go through what's called the cubital tunnel, formed from the medial epicondyle, the olecranon, the cubital retinaculum, also known as Osborne's ligament, and the two heads of the flexor carpi ulnaris. That forms a tunnel that the nerve is going to pass through. It's fairly superficial here at the posterior to the medial epicondyle. If you tap on that area and the nerve is injured in the cubital tunnel, you could potentially get abnormal sensation shooting down into the medial 1.5 fingers and hand. That's called the Tinel sign. So that's assessing the integrity, or assigned to assess the integrity or where the nerve is impinged, and in this case it could be impinged in the cubital tunnel. How else can you, how can you injure it in the cubital tunnel? A common way is hyperflexion, repetitive flexion along with a valgus load. So a valgus load would be a load toward the thumb. So if we pushed on the forearm toward the thumb side, it's putting tensile loading on the medial elbow. That's called the valgus load in this direction. Along with flexion, that actually stretches the nerve. So we see this sometimes in our overhead throwing athletes with overuse type problems, repetitive throwing. As you go into external rotation in the arm cocking phase, along with that valgus and flexion, you could get abnormal tension and stretch of the ulnar nerve, resulting in ulnar neuritis. So that's an impingement in the cubital tunnel. Once you do a lot of hyperflexion, you actually flattens the cubital retinaculum, which decreases the volume of the tunnel. So that's an impingement site. Everything distal, like we said, is affected. So you have a high ulnar nerve lesion either in the arm or the elbow. It's basically potentially could affect all motor and sensory function. Now, as we continue through the tunnel, as it leaves the tunnel, it can also be impinged between the two heads of the flexor carpi ulnaris. That forms a fibrous arch known as the arcade of Osborne. So it can be impinged there, or as it travels through the two heads of the flexor carpi ulnaris. Repetitive use, again, involving a lot of wrist motion and deviation. Overuse of that muscle can compress the ulnar nerve. So it's more of an overuse phenomenon. And that can compress it. As it continues through the two heads of the flexor carpi ulnaris, it's going to run between that muscle and the flexor digitorum profundus, innervating both of those muscles. And then it's going to continue about a third of the way down. In the middle third of the medial forearm, the palmar cutaneous branch comes off of it. So it's going to travel down superficial along the medial forearm, across the medial wrist, and its destination is the proximal medial hand, or the hyperthenar region. Going to supply skin to this area right here. So if you have an injury, a lot of compression over the medial wrist or anywhere along its path, that could potentially cause abnormal sensation in this area right here from the palmar-cutaneous nerve. Then the median nerve is going to continue down. In the distal third, the dorsal cutaneous branch is going to come off, distal third of the forearm. And it's going to travel deep to the flexor carpi ulnaris, and then it's going to work its way around to the dorsal side. So it really doesn't go superficial like the palmar cutaneous does, so a lot of compression here is not going to affect it. It's oftentimes spared, the back of the hand. And then it's going to go to the dorsum, the medial, 1.5 fingers, and the hand on the dorsal surface. So that's what the dorsal cutaneous is going to supply. Then as it continues down, it's going to go through another tunnel. And this is called Guyon's tunnel, or more commonly called Guyon's canal, formed between the pisiform and the hammock and the pisohammock ligament on the roof, and then the floor of it is the flexor retinaculum, or the transverse carpal ligament. So this is important to know clinically that it does not go through the carpal tunnel because it goes above the flexor retinaculum. But it can be compressed in Guyon's canal. How so? Well, obviously if you have a fracture of the pisiform or the hook of the hammock, or a dislocation, that narrows the content, the volume in the tunnel, and that can compress the nerve. Or if you have a ganglion cyst on the volar surface of the medial wrist. Not real common, but it can occur some, and that can compress the nerve. Or if you fall on an outstretched hand, sometimes the pressure there, or again, dislocating the pisiform or the hammock. Or another common one is riding a bicycle, so handlebar syndrome, where you have constant pressure on your bicycle on the medial wrist over a prolonged period of time. That can also compress the nerve. The ulnar artery also travels with the ulnar nerve through Guyon's canal. So you have an arterial thrombosis. That can also cause potential problems as well. So there's several things that could occur here that can cause both motor and sensory abnormalities. Now, sensory-wise, like we said, the dorsum of the hand is going to be spared in this because the dorsal cutaneous nerve doesn't go through this area. The palmar cutaneous nerve does. It can be affected, as well as the medial 1.5 fingers on the palmar side in here. Those can be affected with Guyon's canal syndrome, as it's called, or ulnar canal syndrome is another name for it. So then from there, the ulnar nerve is going to go ahead and continue traveling through the Guyon's canal, and then it's going to split into a deep branch and a superficial branch. The deep branch is a motor branch, and it's going to innervate all the intrinsic muscles except for the 2.5 muscles in the thenar region and the lateral two lumbricals. That's going to be innervated by the median nerve. And the superficial branch is primarily a sensory, but it does have a little bit of motor to the palmaris brevis muscle, which wrinkles the skin in the hyperthenar region, helps improve grip. But other than that, the superficial branch is primarily going to be sensory. So it's going to provide sensation to the distal medial palm and the medial 1.5 fingers here. So it's kind of all in this area here. Now let's go back to looking at some signs. We've talked about a high ulnar nerve lesion and what it can do. What about a low ulnar nerve lesion in here? Well, it's not going to affect the muscles in the forearm. The 1.5 muscles have already been innervated. So it's just going to really affect the intrinsics. So you could have weakness and deformity. Some of the weakness you can have is weakness moving the little finger, flexing, abducting, opposing from the three hyperthenar muscles. The ability to abduct and adduct the fingers like this from the dorsal and interossei. Dorsal interossei abducts, dab, the palmar interossei, pad, adducts. So abduct would be, and adduction would be the function of the dorsal and the palmar interossei. The lumbricals, the ability to flex the metacarpophalangeal and extend pip and dip. That could be affected, but only on the medial 2 fingers, and the ability to bring the thumb up into adduction like this. Now there's some other signs that you should be aware of when you have an ulnar nerve lesion, especially a low ulnar nerve lesion like this. One is claw hand. So if you have the person make a fist like this and tell them to extend the fingers, that's the function of the extensor digitorum, which is a radial nerve. It can certainly initiate it, but the more the fingers extend, it's best at extending the metacarpophalangeal joints. It's not as effective as extending the pip and dip, because the more the fingers extend, their ability to generate tension diminishes. So that's where the lumbricals, primarily, and to a lesser extent the interossei, help extend the pip and dip. But in the digits 4 and 5, the ring finger and the little finger, they potentially could be completely gone. So that's where you get this claw hand phenomenon, where you have them extend their fingers, and these two extend fine, but these two here actually end up clawing. So a little bit like you see here, kind of a claw hand of the 4th and the 5th. Now you get some hyperextension at the metacarpophalangeal joint. That can actually stretch the flexor digitorum profundus, which is still intact with a low ulnar nerve lesion, this medial half. And that can actually exacerbate the claw hand. So if you have them extend the fingers, the extensor is actually trying to, all the muscles in the posterior compartment are actually trying to extend the wrist a little bit as well. To stabilize that, you have some activity from the anterior muscles, including a little bit from the flexor digitorum profundus, potentially. So that tension can actually, as it pulls the dip down from the flexor digitorum profundus, can help exacerbate the claw hand. So again, without the lumbricals working, which do this, you get the opposite response, which is more of a claw hand, and they can kind of adapt to this too through muscle contractures as well. It can adapt to a little bit of a claw hand, or it can be a sign by having them extend the fingers. Other things that you might notice is atrophy of the first dorsal interossei, where this muscle here, which is very prominent, the first dorsal interossei, it can atrophy where there's a great concavity that's very apparent visually that you can see in here. And all the, between the metacarpals, you can see a dip, a concavity in here with severe atrophy. So those are some other signs you can see with ulnar nerve. Other things, if you have the client try to hold a piece of paper between the index finger and the thumb like this, and then you try to pull it out, normally the IP joint is not going to flex. You have the adductor pollicis and the first dorsal interossei that can push down very forcefully like this. But if it's weak, then to compensate, the IP joint will flex like this as you try to pull the paper out. So that's called Froment sign. It's a sign for ulnar nerve pathology. So those are some different signs. Again, the ability to abduct the fingers and other things that we mentioned motor-wise, as well as the abnormal sensation. All those you potentially could observe with an ulnar nerve lesion. So that summarizes the structure, function, and pathology of the ulnar nerve.